We'll just give we'll give them a few minutes to join with us, or a few seconds, perhaps, maybe 30.
You tell me when to share my screen.
Sure, Fernando, will do. Will do. Bear with us. Let them join first. Thank you. Okay, let's begin. Well, good morning, good afternoon, good evening, friends from around the world. If you're watching on YouTube and other channels, most welcome, huge welcome to you. I'm Mansour Faruqi, the CSF section chair, and it's a pleasure today to welcome two colleagues, and in particular our star guest that both Giorgio and I were very keen to invite for this webinar for a long time. A huge thank you and welcome to Giorgio Palandri, my colleague from Bologna, an outstanding neurosurgeon from Bologna in Italy, who's been instrumental in developing the CSF section in Europe and the huge amount of work that he's done to help. And I'm very grateful. Thank you, Giorgio. And thank you for making this webinar happen with Fernando. And it gives me great pleasure to welcome Professor Fernando Hakim. And for many, many years, I was hoping I would meet him, and I did manage to meet him first in Cartagena in Colombia. And as he's the son of Solomon Hakim, I'd like to say, as I said earlier to him, that it cannot be easy for a son or a daughter of such an illustrious father or mother. And in his case, his father has been an illustrious major figure in world neurosurgery, not just because of his work in describing normal pressure hydrocephalus and in his intuition for working on this and his perseverance to describe it, but also his work on hydrocephalus and better understanding of hydrocephalus, as well as dementia. And of course, in developing the Hakim valve and many other services, particularly to Colombian neurosurgery and world neurosurgery. So it's a great pleasure to welcome Fernando Hakim. A reminder for the friends joining around the world, please put your questions in the Q&A section. Fernando will first, I think, concentrate on the history of NPH, and we hope some of the presentation will be his father's legacy, and then how things are done in Colombia, so we can work and work together and learn how NPH and such conditions are managed. So a huge welcome to you both. Welcome, Fernando. Welcome, Giorgio. Thank you.
Thank you very much, Mansour, for your kind introduction. And I must say again, Fernando, how much we are honored to have you here. Indeed, you contributed a lot to the field of hydrocephalus, as ENS section, we like very much to hear from you the first talk, the history of IMPH, and then after a Q&A session, your experience as a center of excellence. Please, everybody feel invited to put your questions in the Q&A button. We will have plenty of time to discuss with the unique experience of Fernando. But let's go to the point. Fernando, you have the podium, and please share your presentation. Okay, we can see it.
Okay, good morning, everyone. I'm glad to be here. Thank you Mansoor. Thank you, Georgia, for the invitation. It's a pleasure to be with such a nice audience. I know I cannot see you, but I know there's a lot of people around. And wait, let me put more. Give me a second. Okay. This is the hospital where I work. It's a hospital in
You're muted now, Fernando.
Oh, I'm sorry. No, this is the hospital where I work here in Bogota, in Colombia, in South America. It's a hospital with like around 500 beds, and it's considered one of the very important hospitals in Latin America. And it's the JCI approved. I will talk about that in a minute. But it's very nice to work. I work with friends in the neurosurgical department. I am actually now the coordinator, or some people say the chief. But I'm happy to work with all my friends. And this work that I'm going to show you, obviously, it was created by my father many years ago. But what we've been doing in the Center of Excellence, I have been doing it with a group. It's not my work. It's a group of a lot of people that we work together. It's teamwork.
I didn't get that. Could you try again?
Bueno, this, I don't know if the Siri went in here. This is, when I talk about normal pressure hydrocephalus, I always have to talk about my father. This is a picture of my father when he was in Boston. That was around the 50s. And when in that specific picture, he is describing, he was working in the lab, in the pathology lab. He taught me a lot about pathology, and he told me it was very important as a neurosurgeon to know pathology. In that same hospital was where he described the normal pressure hydrocephalus. This picture is a historical picture. You can see Dr. on the left side of the screen, Dr. Raymond Adams, which...
Sorry, I'm having trouble with the connection. Please try again in a moment.
Excuse me for a second. I'm having a problem here with CD went inside and... Excuse me. Yo me puedo ver cómo estoy, no me importa. Bueno, okay, Dr. Adams was the person who described, or was the teacher of my father in neurology. Many people of you probably know who Dr. Adams was. There's a very important book in neurology that's called, it's Neurology, and it's Victor and Adams. It's a book that all of us did look over it when we were studying neurology. Dr. Jacobi was a pathologist, and there is my father. So this is a very historical picture because you will see that my father described the normal pressure hydrocephalus with Dr. Adams, and I will let you know some funny facts about that. This is the first time that normal pressure hydrocephalus was published in the journal, the New England Journal of Medicine. As you can see, it was in 1965, and the person who described it was my father, Solomon Hakim. But my father gave the paper to Dr. Adams to take a look at it, and the only correction he did was that he put his name first before Hakim. And so my father told him, Dr. Adams, well, in a very humble way, I was the person who described the syndrome. Why did you change the name and you put yourself first? Dr. Adams said, here in the United States, we publish in alphabetical order. So the A comes before the H. That took a lot of time. And after a couple of World discussions, it was changed, and now today is known as the Hakim syndrome, as all of you know. This was published in 1964. Before it was published in the United States, there was a university here in Colombia that described the syndrome with my father. It was another university here, but it was published first in Colombia in 1964. Let's talk a little bit about the history. These are actual pictures of this thesis and of this article. How can you explain normal pressure hydrocephalus? You would see in those times pneumoencephalography that showed that the ventricles were big. So people will say, okay, this patient has hydrocephalus. They will do a lumbar tap, a lumbar puncture, and you would find that the pressure was normal. So they would say this patient has atrophy. How can you explain that a ventricle is big without having high pressure? That is the first point and very important point to realize. There's why did Isaac Newton notice when an apple went down of a tree and touched the floor? Many people had seen that, but he said, what's pulling this apple down? That's where I believe that intelligent people notice those things. And he noticed, how can a ventricle be big having normal pressure? It's not atrophy, it's something different. So he knew a lot of physics. And here in this picture, I will show it again. And I have pictures and videos of my father talking. Here, I will go fast because I won't have the time. You can see the balloon on the lower part. The pressure is exactly the same, and the balloon is inflated, it's big, as the balloon in the upper part of the movie, of the picture. Both have the same pressure, but one has a big ventricle or a big balloon, and the other one has a small balloon, but they have the same pressure because pressure is equal to force over area. Here you see that you have the same pressure, and one is big and one is small. So what do I want to show you? That the ventricles are big on one side and small on the other side with the same pressure. It's exactly the same. Here is force is equal to pressure times area in both sides. To explain this a little bit better, when you see a lady that weighs 50 kilograms and has high heels with a thin heel, and a person and a male that weighs 80 kilos, walking inside a floor that has wood, who is going to make holes in the wood, in the floor? The lady that weighs 50 kilos or the guy that weighs 85 kilos? The answer, I will give it to you immediately. The lady that weighs 50 kilos, because the 50 kilos are all concentrated in a very small area. That's the same principle of the hammer and the nail. And the other question that I have for you, what has more pressure, the tire of a racing bicycle or the tire of a tractor? The answer, I have it for you here. The tire of the bicycle has 100, you inflate it to 110 pounds per square inch. And the tire of a tractor, you only put 8 pounds of air. The pressure, so what has more pressure? The smallest one. That's exactly the same principle of what happens in the brain. This was the way that it was studied in those days. There was no CT scan, no MRI, obviously. So you can see the big ventricles, the pneumoencephalography, you put air, and you will see the big ventricles here. And with the angiogram, you will see the branches of the anterior cerebral artery, they were displaced towards the cranium. They were displaced cephalically. That was the way to diagnose hydrocephalus. Here, this is my father.
Hydrocephalus can exist in the face of normal CSF pressure. Here, despite identical pressures, The force of the larger ventricles is greater and proportional to the surface area. A demonstration follows. Inflating a balloon requires only a momentary increase in pressure to overcome the initial tension of the balloon walls. Thereafter, pressure drops.
That's the explanation, or like a resume of what I just said. And this other one, this is very interesting. Look at this one. It's also
Symptomatic hydrocephalus can This setup consists of two opposing syringes, the larger on the left and the smaller on the right. They will be activated by a third syringe. The larger one will overcome the smaller one in spite of the pressure being equal in both cylinders.
So with that explanation and those examples, I think you can have an idea of what's happening in the intracranial cavity.
This setup.
So what we say in our Center of Excellence, what we want to do, this is just a phrase of the part of when my father described the syndrome, is rescuing from oblivion at least some of those patients who, in as much as this syndrome has not been recognized previously and have been diagnosed as hopeless cases. I will talk about that. I have statistics of how many people around the world have Alzheimer's and what percentage of those people could really have a normal pressure hydrocephalus. That's why I think I cannot do it by myself. I'm not big enough. No one is big enough. We need to work as a group around the world to do this. Rescue from oblivion a lot of patients that have been diagnosed with a hopeless case patient. The first case is in 1964 when my father described the syndrome. It's very important, the first way to diagnose the patients. There's a triad. The first part of the triad, always, all the patients that have NPH begin with a magnetic gait. They walk like if they had the shoes, metal shoes, and the floor had magnets. Look how this patient walks. It's difficult to walk. They slide. Look at the gait. They can't lift their feet from the floor. That's typical of NPH. If you see a patient walking like that, I can guarantee that he has NPH. And look when he turns only in one foot. We describe that as like a compass. Did you notice that? He turned only in one foot. Please, when you see a patient and you think that he can have NPH, put him to walk and tell him to come back, and you will see that. This is another patient. That's 1964. This is history. Exactly the same. And this is another case. This patient he couldn't even walk. Look at this. That's 1964. That's 2 weeks after the patient was shunted. And this is 3 weeks after. Another symptom is that the patient has problems. He has dementia. And another one, he has problems controlling the urines and deposition. Okay, this is also history. In those days, this magazine was a very important magazine. It was like a Time magazine. My father was going to be in the caratula of the magazine, but in those days they killed Martin Luther King. So the widow of Martin Luther King obviously was more important than a neurosurgeon. So They put it up here. The miracle of a Colombian neurologist. Well, my father was not a neurologist; he was a neurosurgeon. Here are the pictures inside the magazine where he was explaining MPH and hydrocephalus on the left side. I'm going to go a little bit faster, or else we won't have enough time. This was the first. I'm not going to talk about shunts, but this is also history. This was the first time that my father tried the programmable shunt in October of 1985. He did by himself in the lab in our house, this device with this was the superior part of a shaving cap. This was the second floor of my lab where my father used to make the first shunts, where we as a kids worked and helped him there. This picture is also history. That's me. I wasn't there for the picture. I was watching my father work, and they came to take a picture for one of these magazines, and I happened to be there. That's life, and that's me when I was a little kid with my father. I will always remember that. Okay, so in 1964, Dr. Hakim described the disease for the first time, a form of hydrocephalus with normal intracranial pressure. He described the symptoms, the Triad, and designed the ventricular atrial shunt with a unidirectional valve regulated by pressure. And in 1965, he published his findings in the Journal of Neurological Science and the New England Journal of Medicine. Here are historical pictures of the moment. Here are all the first articles. And again, we wish to call attention, this is very nice, on the importance of recognizing hydrocephalus with normal pressure and the opportunity for rescuing from oblivion at least some of those patients who, inasmuch as this syndrome has not been recognized previously, have been diagnosed as hopeless cases of post-traumatic encephalopathy or Alzheimer's dementia. That was Solomon Hakim in 1965. Now, let's come, probably, this is the, yes. Here is, that was the history, obviously, of normal pressure hydrocephalus. And now I will begin to talk about our experience. But before the questions, I would like to talk a little bit about this. We have the Joint Commission International. What is Joint Commission? The hospital, in our hospital is Joint Commission. And our center of excellence, the MPH, is the only center of excellence approved by Joint Commission in the world. What's Joint Commission International? Is the world's leader in healthcare accreditation and the author and evaluator of the most rigorous standards in quality and patient safety. So we're very proud to have a center of excellence acquainted by the Joint Commission International. To have this, you have to have a hospital that is JCI approved, and then you can do the center of excellence. I'm going to show you how we did it. But I know there's some questions, but if you want to, Giorgio, we could stop here. And if you have some questions about the history, and we can keep on in a moment about how we do it in Colombia.
Yes, sure, Fernando. Thank you very much for sharing your father's experience. I have some comments on what you said. The first one is that at the time, they didn't have the concept of raised ICP with normal ventricles. That was, I think, the great intuition of your father. I could say that, and maybe you can comment on that, your father was very curious. He was a very multidisciplinary man, because from the very beginning, he studied the specimens. He had already observed that many of the elderly died with enlarged ventricles. He was starting from the very beginning thinking of the problem, and then he was able to combine his observations with the physical laws. You mentioned, for example, the Pascal law, which is fundamental to explain why ICP is not raised with the enlarged ventricles. So I think that it is very important to be curious, and I think it has been very important for your father, but even for you, when you comment the picture in which you and your father are together, you say that it happened. But in my mind, nothing happens by chance. The key point is to be there, is to be curious, is to have the chance to combine your thoughts and to make experiments. So could you please add something to that?
Yes, I believe that some people say you're lucky. You're a lucky guy, but I mean, I was born in this family, and I can't change that. And some people, I had the opportunity to be motivated by my father since I was very little. My father did that not only with me, but with my other brothers and with my sister. That was around my family all the time. I mean, as I show you, the second floor of my house was a lab. He was always working in the lab. And I personally love cars, and I used to go up in the lab, and when I needed to do a special device for the car, I would do it there because we had everything. And one day a person asked me, who was your teacher in neurosurgery? Who were your teachers? And I started thinking the names of them. And before I opened my mouth, after like 20 seconds, I said, the most important teacher was my father, because he was there with me every day at breakfast. He would tell me stories about a patient, and I would learn the story without feeling that he was teaching me. That's the best way to learn. When you have to sit and you're not motivated, you will never learn because your brain is not ready to connect your neurons. You can't do synapses if you're not paying attention and if you're not really motivated and interested in the subjects. So I remember one day talking about a disease. I told my father, I saw a patient that had atrophy in the hands. I was a medical student. And he said, please go and ask that patient if she feels the temperature in the hands, the difference between cold and hot. And definitely she didn't feel it. And we studied the patient in those days, and she really had syringomyelia, secondary to a Chiari syndrome. And that's the way I will never forget. And I love this disease because my father taught it to me that way. So it's very important in life to be motivated with what you do. The last picture of this presentation is a sentence of what my father thought how you should be doing in life. What would be your motivation? I'm not going to say it now, so you pay attention until the end of the talk. The last picture will say what my father thought of life. And so I think it's very important to be motivated, and always, as I always tell the medical students and the residents, please be motivated with what you do. If you're motivated and you're in love with what you do, you'll be great, and you'll do great. It's hard sometimes, but that makes the difference. The person that is motivated, the person that studies, the person that dedicates time to something, and if you fall, raise again and keep on working, keep again and work. Resilience is very important. Yeah. And persistence is the key. That's all I have to say.
Yeah, I think that this is where curiosity comes from. And another story which you didn't tell us, but I found it on the paper, is that in the very beginning, your father was discouraged by Dr. Adams to publish the paper. Because when he noticed in the very beginning that there was an association with large ventricles and normal ICP, Adams told him this is already a very well-known fact, so there's nothing to publish there. So I think that one message is curiosity and resilience, as you told us, to be in love with what you do. And the other thing, I mean, there are lots of young people here listening to you, is that not always, of course, you should keep in mind other suggestions, but you must follow also your instinct, because in the very beginning, even your father was discouraged. You're muted.
Yes, yes, you're absolutely right. That's, I mean, if you fall, you have to stand up again. All I can say is that at the end, my father gave the paper to Dr. Adams, because Dr. Adams was the teacher, his teacher, he's a neurology teacher, and he looked at it and he recognized that he really had something in his hands. It was a new syndrome. But the only thing he changed, not a word inside the article, but just he put himself at the beginning, Adams and Fisher and then Hakim, because in the United States, they publish in alphabetical order, which it's not true. But after all, that Dr. Adams was a very important person. I met him when I was in Boston. I had the opportunity to meet Dr. Adams. I met Dr. Sweet, of the book of Schmidek and Sweet. I met Dr. Miller Fisher. He spoke to me many times. I even have a picture of himself. When I decided that I finished there, I came back to Colombia. He put his name and he talked to me. He was a very, very nice people. So I believe that I've had the opportunity to meet very important people in life. That's what you have to do. See the life of those people, and that will motivate you for the rest of your life. That's very important. And I feel that I vibrate in the same frequency that those people did, even though they were monsters. We're not monsters, but we're happy with what we do. And that's what we have to teach our sons, our daughters, and our residents and our medical students. That's what we have to do. Thank you.
Thank you so much. Maybe Mansour, you want to add something?
Well, I think it's been profound and fantastic to get a glimpse into this and to be inspired as to sort of when to forgive, when to be detached regarding sort of names and titles, and when to seek justice for the sake of, principle. I have a question for Professor Hakim. It is this, that I look at the facts as much as possible. And the fact was that he drained CSF from the cerebrospinal fluid compartment via spinal tap, and the patient got better. And that's undeniable, no matter what the hypothesis. And whatever the theory is at the moment, whether, and absolutely the Laplace's law and the basic physics principle is sound. But where do you think is the pathophysiology for this condition? Is it an obstruction? Is it a combination of things? Is it, as many people think, the obstruction between the cranial and spinal compartment of CSF? Is it much to do with the pulsations and the wave formats? And along those lines, about the pathophysiology, what would be the explanation that someone will have dilated ventricles for years and be coping and be well, and then suddenly tip over the edge? I wonder if yourself or your father shared any more thoughts about that.
Yes, we have the idea of what's happening. I mean, if I say what we're working on, I mean, my brothers will be very mad with me. So I cannot. There's a theory that explains exactly what you just asked. So we have to publish this before. I think it's the way to go. But soon we will publish it, and you will know. It's very interesting. It's very interesting. I'll ask you another question regarding the same subject about CSF hydraulics. Why does a person with pseudotumor increase the intracranial pressure and you don't see nothing in the size of the ventricles? Yeah. Can you answer that question?
I wish I could, and it was about the same lines, but the way I try to look at it as one individual is that surely it cannot be one size fits all. It's multiple factors. But what it should come down to, perhaps, is that ultimately, whatever happens, it's the microcirculation of the brain that's affected. So somehow the pulsations, the circulation, the oxygenation is above that critical level. And I agree absolutely. I'm as a junior, I've done TAPS where the pressure's been over 45, 50 in IIH. And you think, how's this patient even talking to me so well? Absolutely, but surely it must be more than just one principle. It's a combination of things. And I don't know what is the answer, but I have a feeling that it's not always one answer. It's a number of factors for the patients involved, but there can be very common factors. Ultimately, it must be microcirculation of the brain is compromised beyond that critical level. And I look forward to your paper. It would be fantastic, I'm sure. Thank you, Fernando. Thank you. And Giorgio.
I could talk a lot more. This is very interesting, Mansour. This is very interesting. We could keep on talking because I have many, now that you asked me this, I have a lot of other questions to ask and other questions to answer, but we don't have the time. I would like to have more time, but we don't have the time.
Well, we are receiving congratulations from the audience, and maybe we have a time for a brief question. How do you explain the symptoms of the triad?
That's a good question. Everybody has heard about tractography. And we've seen some studies that we've done some, what happens to the brain in the tracts, the motor tracts, and the tractography with hydrocephalus. You've seen the highways or the cortical spinal tract is near the ventricles. So when the ventricles increase, you compress that tract, and that's why the person has a problem in the gait. Obviously, the dementia is also secondary to the distortion of the cortex of the brain. And also the incontinence is probably that's caused because of the distortion of the incontinence. That's the way we see it in 3 words.
Okay, thank you very much. I think we can move on to your second talk, Fernando.
One day I was walking in the hospital and I saw that there was a clinics of a center of diabetes and a center of high blood pressure. And I said to myself, why not do a center of NPH? So we started with one of the neurosurgeons and a couple of nurses and a couple of students. We started working on that, and we decided to do a center of excellence. And then we called the Joint Commission, and it was approved. But how do we do it? And what was the motivation to do this? Look, around the world, there are approximately 6.5 million of Americans that age 65 age and older are living with Alzheimer's. That was in 2022. Imagine that about 1 in 9 people, those are 10.7% of people over the age of 65 have Alzheimer's disease. Around the world, there are around 50 million people worldwide living with dementia. The number will almost double in 20 years, reaching 82 million in 2030 and 152 million in 2050 with Alzheimer's. 60% of the people with dementia live in a low and middle income countries, but by 2050, this will rise to 71%. So that means that we have a big problem with Alzheimer's. Now let's talk about NPH. 0.5% of the people of the age of 65 could have NPH. The total population of the United States in 2019 was 328.3 million. That means that 0.5 will be, that means that 0.5% of the people, how many people over the age of 65 are of those 328? 52 million of people are 65 years and older. And 0.5% of 52 million is 2.6 million could have NPH in the United States. And that goes high, it goes a lot higher when you're 70 to 79 and when you're over 80, 5.9% of the population could have NPH. That's one of the statistics you can see and find around the world, different numbers, some go down to 4. But anyway, it's a big problem, and there's a lot of people that if you recognize this syndrome, you can treat and you can help. If we could help all those people that really have NPH and have been called to have Alzheimer's, we would be doing a very big job. That's why I called the world and all of us that work with this disease, if we could all work together. In the United States, there are 700 people are diagnosed in the United States, but there are only 18,000 have received treatment. So there's a lot of people that have not been treated, and in the United States, that's the reason of this picture. This is important. In our Center of Excellence, this has not been published, but it's written here because this is what we found. 36% of the patients that have come to us had a prior diagnosis of a neurodegenerative disease like Alzheimer's or frontotemporal dementia, and we have helped those patients. 36% of those people had a diagnosis that was incurable, like Alzheimer's or frontotemporal dementia, and we have helped them when we found that they really had NPH. Here, it is important to say that a person can have both diseases. You can have NPH and you can also have Alzheimer's. What can we do? We can help the part of the symptoms that have NPH when we work on this patient and we shunt the patients. Obviously, the Alzheimer's or a degenerative disease will keep on having the patient each time worse, but we can help the patient for sometimes if it has also NPH. Not everybody has NPH 100%, but you can have NPH and Alzheimer's. I've talked about this already. How we do it? There's a clinical triad. There's a gait dysfunction. There's a magnetic gauge and a compass-like turn, as I showed you. There's a cognitive dysfunction, executive skills dysfunction, short-term memory disturbance, and slow information processing, and urge of urinary incontinence. Initially, the episodes of urine leak occur because of the limitations to reach the toilet. The patient can't walk fast enough. And then in the advanced stages, the patients show complete loss of bladder control and also fecal incontinence. It's probably secondary to the frontal lobe syndrome. He doesn't recognize what he's feeling. If we have a patient that has one or two of the triad and also the radiological findings, here is what we do. Here's the Evans index. This is I'm showing it slow so we can see the MRI, and you can start seeing that the temporal horns are big. Now you can see that's the Evans index. We measure a line between the frontal horns and a line between the interparietal diameter distance. And we put it, the denominator and denominator 55 or 138, and that's the Evans index. If it's more than 0.3, you have hydrocephalus. So that's the first thing that we looked at. I think it's very interesting to see the other important thing is the DESH. This was described in Japan. And you can see that here, where you see the arrows, you can see that the cortex, you don't see a CSF. It's compressed there. If you see, it's actually that disproportionate enlarged subarachnoid space hydrocephalus. You see that here is the brain is like compacted, but you see here in the fissure, in the Sylvian fissure, you see a lot of CSF. You see that disproportionate in the subarachnoid space, you can think about the MPH. And also, here you can see it. Look at this patient. You see the big ventricles. You see this very big here. And you see here dash. There's a disproportionate between this and this. And also the corpus callosum. If the angle is more than 90, then here, as you see how we measure it, then we also think about MPH. Now, let's talk about, so that's the criteria to bring a patient to our clinics, to the MPH center. You have to have, obviously, big ventricles, but before that, you have to have at least the gait with the typical characteristic, as we just saw, the magnetic gait and the compass when you turn, and incontinence or mental problems. I will show you this case. The best thing to learn is seeing cases. This is a 76-year-old lady, was an architect, was a member of a work group and was responsible for organizing the meetings 3 months before. She had gait dysfunction, instability, loss of strength in extremities, magnetic gait, difficulties to stand up, and a compass-like turn. There was a cognitive dysfunction, slowness, inactiveness, and tasks needed for help from family members, decreased attention, and in specifically this patient, she wouldn't talk. She was like a phasic. There was bladder control, and there was it was incontinence. She was the history of a CPA angle that was treated with gamma knife. Look how she walked. You see the magnetic gait, very typical of this problem. And look how she turns. This is the time up and go test that we do. That's one of the tests we do before doing the lumbar puncture. Okay. These are the findings. The Evans index was 0.34, and you can see the big ventricles here. So if we have a clinical suspicious of the patient, then we would see that he has big ventricles, and there's a suspicious of the patient as well. I just said, that's the first case. Then we bring him into the hospital, and we're also doing something very interesting, which is the SARIT, is a caregiver overload evaluation, because many times you see that the patient has a lot of problems, but nobody is measuring how much problem is there, the overload of the caregiver. You have to take him to the bathroom or change the patty and no scars. You have to be a lot of time with that patient. The overload of the caregiver is very big. Then the third phase is the preoperative outpatient. I'll show you in a minute what we do. Then we do the surgery, and then the fifth phase is what we do after surgery. When we bring the patient into the hospital and we film the patient, the time up and go, I will show you that in a second, and 10-meter test. And we will be tested by neuropsychology, and after that, rehabilitation and physiotherapy, and then we'll do the lumbar puncture. This is very important part of the talk. Always do the lumbar puncture with an 18-gauge needle. So you leave a big hole in the dura, and so the patient keeps with a fistula, and inside fistula. And there's a question that many people always ask: how much CSF to take out? The answer is not the amount of CSF that you take out, is you have to take out enough CSF to lower the pressure to zero. That's the important, and that's the take-home message. The closing pressure should be zero, not 20 cc's, 30 cc's, 10 cc's. Sometimes you lower the pressure to zero, taking out 20. Sometimes you need 50 cc's to lower the pressure to zero. So that's what you have to do. Lower the pressure to zero, and always do it with an 18-gauge. Look at this. We do time up and go and 10-meter. This was, you saw this already. This was before doing the lumbar puncture. You saw this. This is the time up. This is the time up and go. She was like 3 meters, returns. You saw this. So I'm going to show you 24 hours after the lumbar puncture. She's walking a little faster. So we take time and look, she turns a little bit better. And the 10 meters, we time, see how long it takes. And then 24 hours afterwards, we do this again after the lumbar puncture. Always remember, do the lumbar puncture with an 18 gauge, lower the pressure to 0. Look how she walks 24 hours after. There was a significance. This is one of the tests that we do with the neuropsychological examination. For me, is one of the most important parts because they can tell you if this patient has a dementia secondary to an Alzheimer's or secondary to normal pressure hydrocephalus. And that, why is it important? Because you can tell the family, your father has NPH, but it also has Alzheimer's. If we shunt the patient, he will be doing better from the part of the NPH. The Alzheimer's will keep on, and he will, at the long run, have Alzheimer's. But we can help him for a couple of years at least. And this is one of the tests they do. This is the King test. They show them this. Look at this patient. She did this before the lumbar puncture, and look, she was more accurate after the lumbar puncture. 24 hours afterwards. That's what we do, 24 hours. And a lot of other tests. And then we measure the characteristic of incontinence and interference in everyday life. The patient didn't control she was incontinent, urinary incontinent, and after the lumbar puncture, they started saying, oh, I need to go to the bathroom. That is very important. Another important thing is that after they go out, and I'll let you know in a couple of minutes about that, but the patient goes out of the hospital 24 hours after the lumbar puncture, and we will be communicating with him, with the family between day 4 and 7, because we've seen that they do a lot better after day 4 and 7, and they send us a lot of videos. Okay, how we do it? This will probably not be the time to talk about. We do VA shunt. Why we do VA shunt? That will be a topic for another conference. But in this book, that's the Schmiedecken Suite, edited by Dr. Q, Alfredo Quiñones Hinojosa, the chapter about CSF shunting, it was written by us, and we have all the videos and everything in that book. We have the VP, the lumbar peritoneal shunt, and the VA shunt. I don't know why we do it into VA shunt, because the atrium always goes to 0. At the intra-abdominal pressure never goes to 0. It hardly ever goes to 0. And I have to give a talk in Hamburg about why VA. I've been working on it. And one of the things that I've noticed is that many people do VP shunt because they were taught that VP shunt was the way to go. But if you ask them, why is VP better than VA? Probably most of the residents or most of the people that do it don't have the answer. I will have the answer for you there. It's the way we do it. It's very easy. I was in England one time, and there was a doctor that asked me, do you still do VA shunts? I said, yes. And as your father taught you, yes. And then I told you, do you do VA shunts? He said, no, neurosurgeons are lazy. We like to do it the easy way, and it's a lot faster to put it do it VP. But with this technique, with a peel away technique, in 5 minutes, you have the catheter in the right atrium, and it works a lot better. This is how we do it with the peel away. Another detail is when we put the shunt, the day that we shunt the patient, we don't lower the pressure. We know what the pressure was when we did the lumbar puncture or the spinal tap, but we also measure, is another take-home message. We always measure the pressure inside the OR. We tap the ventricle and we measure the pressure, and we only lower it 1 centimeter of water or 10 millimeters of water. If we found 150, we will leave it at 140. That way, we will have less subdural collections. And we also have a lot less subdural collections because we put it to the atrium. We don't put it to the abdominal cavity. Well, this is the vein dissection. It's a lot faster. We're taking, this is all the surgeons of the hospital, where now with VA, it's taking us less than an hour, even though we do it with the residents. Here's the technique how we do it, but I don't think it's the time to show you, well, I will show it to you fast since I have it here. Just take a couple of minutes. Here's the patient. We only leave this part without the Jovan. We use the echo, and you will see the vein. This is the vein. This is the carotid artery. The vein, when you press the vein, it collapses a little bit. Here, we're going through, and you will see the blood comes out. Now we don't even do negative pressure. Now we just put it inside the vein, and here you see the blood, and then we put the flexible. This is a real time. This is not edited. It's actually almost real time. We put in the guide. Look here how it looks in the echo. See, you see it coming in, and you see it inside the vein. This is the artery, and this is the, and then we put in the other part. That's the part that's going to be peeled away. You see it in a minute. Guide removal, the catheter insertion. It's in the catheter tip in the right atrium. And that's all. Why VA? More constant drainage pressure, less siphon, shorter device, less biofilm, shorter surgical time, and a lot lower shunt dysfunction. Now, this patient after a year. Before 3 months, 6 months, and a year. That patient was rescued from oblivion and was probably a hopeless case. This is something very interesting that we're working, and we're going to take the paper to the Hamburg. Do you think this is atrophy or normal pressure hydrocephalus? This is very important because when you see this MRI, you see this, you think this is atrophy. And if the radiology says it's atrophy, and the people that don't have a lot of experience read the paper of the neuroradiologist that says it's atrophy, the patient has atrophy and there's nothing to do because atrophy doesn't come back. But we've seen that atrophy, it's pseudoatrophy is what we've written in our paper. Look what happens when you shunt the patient. And this is actually real. Look at this. The same patient, we shunted the patient. What happened to the atrophy? Look at this. Just look at this around the insula. We've seen that the people can increase the amount of brain after the shunt, what was supposed to be atrophy, in around 8 to 10%. Those cases, we believe, that have less atrophy or pseudoatrophy are cases that are typical cases of NPH, not cases of Alzheimer's. Alzheimer's really have atrophy and they won't come back, but NPH does come back. This is what happens in a picture of when you shunt a patient that has NPH. Please notice that in the next cases that you do. I always show this picture. This person here, with his permission, was one of my internal medicine professor, who was diagnosed with a very bad disease. He was in a wheelchair for 2 years or 3 years or even more. What he really had was MPH. We shunted him, and he's painting again, happy and doing well. This is the way we've been working since 1964. And here's when we decided to do the proposal of creating the center. I always talk about Dr. Rigamonti because 10 years ago in October in 2013, I went to see him at the Johns Hopkins, and he was a very special person with me. He has helped me a lot, and I believe him like my godfather. He's really helped me a lot. And then in 2016, we did our course in Cartagena. In 2017, we had the first Joint Commission, well, in 2020. And now in 2022, we talked about this in the World Neurosurgical Meeting. And we've been talking in all the meetings of the International Society of Hydrocephalus and CSF disorders. I'm very glad to say again, we are Joint Commission International, because this puts us aligned in a very high mode. This is what we've been doing around the years. This is not work of one day, but as I said, you need to have resilience. I've had the opportunity to work with medical students that are absolutely beautiful. They like to work. They're young. Their brain is young. And in this moment, I have the doctor that works with us in MPH, watching this talk. And she has helped a lot. And it's the way to say thanks to all the people around. Here you can see this was also another medical student that went with us. We've worked with a lot of medical students, and they really are the people, and the young doctors are the people that are behind us and are really helping us. So I know there are probably many medical students and residents that are hearing this talk. Please keep on, and it will be glad if we could help and teach you a little bit of what we know. We've done a lot of papers. This is a poster that we did in our hospital that says it could probably not be Alzheimer's. If a person that has Alzheimer's and they see this in the hall of a hospital, they will start thinking if their father or their grandfather has Alzheimer's, or they really have another disease. So they come to you. And there's where I can tell you that 36% of those patients that have come to us thinking they had Alzheimer's, we have been able to help them. We've done a lot of talks with the patients, and we've written with a lot of articles. We've treated 162. We've seen 162 patients. We've treated and diagnosed 73% have been diagnosed with MPH, and we've treated 46% of those. And of the operated patients, 36 had a previous degenerative disease diagnosed, and all of them improved after surgery. We've treated up to date 75 patients intervened to date. We've had 7% subdural hematomas that just by increasing the pressure, most of them disappear, and only 2 require surgery, but one of those patients had traumatic brain injury and was anticoagulated. But 97.2% of the patients have improved at least one of the MPH syndromes. This is another case of MPH. I like to show this picture. This patient wouldn't walk. Believe me that he couldn't walk. And look how he's in a park running absolutely perfect. And the last one I want to show you is this one. Look at this patient. Look, my turns in compass. She was shunted. This is a couple of months afterwards. She was walking around. She was in the grocery store. And then she was dancing. Back to life. Rescued from oblivion. So again, we rescue from oblivious. Some of these patients have been as much as this syndrome have not been recognized previously and have been diagnosed as hopeless cases. This is the last picture. If you want to succeed in your life, feel in honeymoon with your work, with what you do. If you feel in honeymoon with what you do, you will always be happy and you will always succeed. That's my father in his lab. Thank you very much. I don't know if you have any questions, or we have time for questions.
Thank you very much, Fernando. You were indeed inspired by your father, but now you are really inspiring us too. So I think we have many questions from the audience. One is from Afghanistan. They have only mid-pressure VP shunt available. What is your advice for IMPH operations? This comes from Dr. Fawad Pirzad.
If I understood, is that they only do VP shunts? What is my advice?
No. They have only fixed pressure valves.
Okay. Well, that's what happened with all the cases that I showed on my father in 1964, because the programmable valve was actually came out like in 1990 actually. Usually you have to put a shunt. That was what my father did. If you have a pressure of 130, I would put a shunt that would be like 30 less. If you go too low, too fast, you can have subdural hematomas. The problem of those shunts is that you don't have a steering wheel to guide the pressure of the patient. So if you put the shunt and you only lower 30 and the patient still has symptoms, then you have to pump the chamber of the valve to lower the pressure or change it to a lower pressure. But the best way to go is to use a programmable valve, especially in normal pressure hydrocephalus.
Okay, I think we can skip a question on pseudoturnus cerebri. Maybe we will have time another time. This is from Magda Garzon. It seems that the physiopathology and features of IMPH have been well described. However, the management doesn't finish with the CSF shunt, and I think we can all agree with that. I think that the disease somehow progresses and there's always a need for resetting of the pressure. What is your experience about it?
First of all, you have to be sure if that patient has been diagnosed correctly. I'm sorry to say, but that patient could also have Alzheimer's, a little bit of a degenerative disease. Every brain keeps on getting older with time. So if that patient is only MPH, probably he will do a lot better. But if that patient has a little bit of Alzheimer's or a little bit of degenerative disease, the disease will keep progressing, because MPH really that I know that keeps on progressing a lot. It probably has a combination of MPH and a little bit or Alzheimer's. So that's why it is very important to do the neuropsychological tests. That's what I said that in the talk. It's very important. It can help you know what the patient really has.
Okay, this is another question from Ali Sulaiman. Are there any specific factors that predict the success of the shunt procedure, or factors, on the contrary, that may make the shunt not an option?
That's why you have to do the lumbar puncture. You can't shunt a patient without knowing if it really has MPH. You can think it has MPH, but you have to do the test as I show you. And if you do the lumbar puncture is shunting a patient for 1 day or 2 days. And if it really is doing a lot better, and the neuropsychological test and the gait test and everybody thinks that they are doing in an objective way, did a lot better, you should shunt the patient. And that way you will have a success with the patient.
Okay. This is anonymous. How do you decide which atrophic patients will benefit from shunting?
No, I don't. It's not atrophic patients. What I show you in that, the most important thing of a patient is the clinic. In radiology, they only see a picture. But if you see a picture with a little bit of big ventricles, but they don't have the ace of the poker under the sleeve. But if you know that that patient has gait, magnetic gait, he has MPH, plus the ventricles are a little bit big, you shunt the patient. I mean, you do the lumbar punctures, you do the test, and the patient does a lot better, then you shunt that patient. I'm not going to shunt the patient that has atrophy. That's not, they probably, I mean, it was a misunderstanding.
Okay, thank you very much. If during lumbar drainage test, the patient develops meningitis, when do you restart testing? After antibiotic treatment?
What is the question again? Yeah.
The question is, if the patient after the TAP test develops a meningitis, when do you restart the testing? After, for example, the antibiotic treatment?
Oh, yes, yes, yes. When you have a patient, we never treat a patient that has another comorbidity. If he has another thing, you have to treat that before beginning to, because if you have meningitis, you can't do a test. You're not going, your brain is not going to function well. You have to be 100% well without meningitis.
Okay. What do you think? This is from Melike Mut. What do you think about gravity-assisted valve systems?
Yes. They can work. My father did, and he had one of the first gravitational, like an on and off shot. We have the patent of that. But I think that those shunts, you don't need those shunts if you do a VA shunt. If you do a VP shunt, you will probably need that. But a VA shunt, I have the feeling that in the future, the VA shunt, we have been insisting that it's a better alternative, and I will show you why. Many people are going to begin to use the VA shunt. Because, as I said, why do you use VP shunt? Because they thought your VP shunt was good, but do you have a scientific reason to use it? I can have a scientific reason to show you why, with numbers, why to do it VA and not VP. That's interesting. We could talk about that.
Okay, that will be interesting to listen to your talk in Hamburg.
Yes.
Yunus Aydin is using a flow control shunt in his patients. Any comment on that? Flow control.
Yes, but it's better. It's not. This disease is not a fluid controller. It's better pressure. Pressure is what we see. We have to lower the pressure, not control the fluid control. The amount of liquid is pressure. You have to lower the pressure. You have to create a gradient so the ventricles really go small or have less compression to the cortex. Lower the pressure. That's the most important. Let's talk about pressure.
There's another question from Adrian Caceres. Can you explain why some patients will improve after ETV?
ETV is like doing a lumbar puncture, but through the brain. That's my opinion. They will improve at the beginning because you take a lot of, when you do an ETV, we all do ETVs for other diseases, and you will see that it really takes out, you take a lot of CSF during the procedure. That's why the people improve a lot. But I am almost sure that at the long run, it's not going to be a week or 2 or 3, but in a couple of months again, the patient is going to need a shunt. I saw it recently in a patient that they had an ETV like 3 weeks before, and he came, I saw him, and he's not walking well. And I asked him, are you doing well? He said, no, I'm beginning to feel bad again. That's my opinion. We could talk about that also.
Yes, so it's a kind of TAP test in ETV.
Yes, but it's because the ventricles will go smaller. You have to lower the pressure under the pressure of the superior longitudinal sinus. You have to lower the pressure under that. And with an ETV, you can't lower the pressure like that. You lower it with a shunt. That's the answer.
This is another very interesting question, at least in my mind. What is the role of multiple lumbar punctures to increase the sensitivity of the diagnosis? Do you use multiple lumbar puncture or no?
That's a good question. If we've seen in patients that have had the normal pressure hydrocephalus for more time, that one lumbar puncture sometimes is not enough. What we do in our program is that if we do a TAP test, we've done it like 2 times. In that professor, my professor of internal medicine, I did the 2 lumbar punctures because the first lumbar puncture, he was doing a little bit better, but I was absolutely certain that he had MPH. I did another lumbar puncture. I sent him home and he did a lot better. So if you don't see a lot of difference in the first one, you could repeat even 2 or 3 lumbar punctures. But importance of the lumbar puncture, lower the pressure to 0 with that 18 needle gauge. Because if you take out not enough CSF, you didn't create a gradient and you didn't do enough. And the bad thing is that you did the test, which is a tap test. And if you didn't do it correctly, that patient is going to have a false positive, okay?
Okay, thank you very much. I think that you already answered the question. Is LP standard for your all patients? If it is not, how you decide? I think you clearly answered that it is a standard. Do you use any pharmacological treatment for IMPH?
No. No.
Okay. And this is another reasonable question. What is the rational time for testing after the tap test?
For testing or for shunting?
No. When do you
test the
evaluate patients
okay,
after
24.
the tap test?
We do it. It's the way we do it is 24 hours. We even put the time of the tap test was at 13:45. The next day at 13:45, all the tests begin. I've seen it. I saw it in Johns Hopkins. It was 2 or 3 hours after the test. I saw they did the tap test, and 3 hours later they were testing the patient again. But what we've seen is 24 hours, and then between the day 4 and 7 after the tap test, we've seen that they do a lot better.
Okay. Do you use external lumbar drainage at your clinic or not?
No, and the reason is that I've seen that the problem with that is that you don't lower the pressure enough. I've seen patients that you take out 15 cc's every hour, but did that lower the pressure to 0? If you don't lower the pressure to 0, you're taking a lot of CSF, but in an hour you produce 15 to 20 or 15 cc's of CSF. So you didn't create a gradient. You take out 15 and you're producing 15, you're not doing anything.
Okay. And speaking of the MRI, which is the role of the flow void signal in the MRI, in your experience? Do you take that into account for the diagnosis?
No, we don't. We haven't, no. But when you say flow void signal, in what part? In the third ventricle, where?
No, I think that he or she is referring to the aqueduct.
No, we really don't take a lot in account. We see more the dash. We see the transependymal fluid or the white in the T2. We see the size of the ventricles. We see the size of the Sylvian fissure, and we see dash. Those are the most important things. And the form of the third ventricle, usually we see it like more rounded. In Alzheimer's, is more square.
Well, I think we have 2 questions that will be answered in another webinar. What is the cause of IMPH in your opinion? We already debated a little bit about that. And why is ventricular arterial shunt better than ventricular peritonal? I think that Dr. Sheehy, we invite you to follow Professor Hakim in Hamburg for the Hydrocephalus Society Congress, and he will give a talk about that, and maybe we will have the answer and we will convert to VA shunts. Adrian Caceres is giving you his congratulations, and we join him, of course. Have you performed cribbage of the dura on initial LP? That means multiple holes after obtaining CSF. So kind of complication.
Yes, no, that's a good idea, and I didn't say about that really. Well, when we finish taking lower the pressure to 0, before taking out the needle, we take it out a little bit, we angled it a little bit, and we put it in again, like a couple of ways, just to create more. That's a good idea, to create more fistula. That's a very good idea. I didn't say about that. Thank you.
So I think that maybe we are in the end. I will ask Mansour to end the session.
Giorgio, very kind of you. Fernando, excellent. You know what? I've got lots of questions myself, and listening to this, we can't say enough how good it'd be for us to get together in Hamburg and also in Barcelona. So Hamburg in August and Barcelona in September. A few quick comments for you, and in sympathy to some of the questions, and for Fernando, and then one question to follow, if I may. A comment about the brain change that you saw with atrophy following shunting. I've seen that, and another very senior colleague who taught me a lot of neurosurgery, Fred Nath, many years ago, said to me, if you hydrate a patient well when they're in hospital, they can go from an atrophic looking brain to a fuller brain when they're well hydrated. And I've not forgotten that, and I've seen that a few times, although it'd be good to look at it in a scientific way with any series. Regarding the choice of shunting, it makes a huge difference on the valve. And I think what's happening now is that in different parts of the world, in UK, one particular, more like one ethos with VP shunting, in Japan, a different with LP shunting, with yourself in Colombia, many others, VA shunting. Depending on what valve and what technique you use, you will then get used to a particular valve. But I can't help feeling that it's not just about the pressure, it's about the waveform, what's happening in the waveform before shunting and afterwards, and not just a drop in pressure. Because as we know, when you're lying flat, your pressure could be 10, 12, 15, but when you're standing up, it's sort of -5, -6. So with that in mind, in sympathy to others, if, for example, you do VP shunting, what we're finding with programmable valves is that you can drop the settings of the valve to 0, but you need to have a fixed anti-gravitational about at least 25 or +30. And it makes a lot of difference, but in VA shunting, it would be different. So with all that in mind, a quick question for Fernando. This is very important for me and for many around the world. What do you think about testing? Do you think there's going to be a time soon when the risk from the shunt is so low that when you see a patient with barn door NPH with good radiology, that you might say, for a large portion of them, let's just go ahead and shunt them? Because so many with negative tap test and negative lumbar drainage test and negative infusion and drainage test, 20 to 30% in some series will still respond to a shunt. What do you think about saying, I think we should just go ahead and do a shunt? Because I'm increasingly doing that, and I know others are. I would appreciate your thoughts, and even Giorgio, not even, of course, Giorgio.
Well, we never do that because we always do a tap. That's why I encourage you to do a tap test with a needle 18 and lower the pressure to 0. As I said, if you do infusion tests, if you do you put a catheter, but you don't create a gradient, you don't lower the pressure enough, that patient will not do better. And you have a diagnosis that is not accurate because you didn't lower the pressure, but you did the test. So that is not a good candidate. But the problem is that you probably did the test not in the correct way. So if you lowered I've seen the patients that if you lower the pressure to 0 and if you have NPH and you do out the other tests, they will do better. And in the day 4 to 7, they will be doing a lot better. I also, one day I was thinking, if you have enough experience, have you seen many patients with NPH? I just had a case, the one that I went to see last week. The daughter of the patient said, will you, why, if you know that my father has NPH, why do you need to do a tap test? It's a very intelligent person. She asked me that and said, you're absolutely correct. And I probably have enough experience to know that your father really has NPH. He has big ventricles. He has magnetic gait. He has compass turning. He doesn't control. He's demented. He has NPH. So probably you, in those patients, you could probably put the shunt. But what happens if you don't have enough experience and you start putting a lot of shunts in patients that really don't have NPH? So the syndrome, then the people are not going to believe in the syndrome. If you put a shunt in a patient that they don't really have NPH, then NPH doesn't exist. So that's what...
Fernando, that's excellent. I agree. I mean, I'm about to do a very complex patient with a period of lumbar drainage, which is unusual for me because I do infusion and drainage test in one go as a day case. But the question is, what about the ones who are negative? You in your private clinic, you will get, I mean, I've seen plenty, which is really hard. And recently, a few weeks ago, I shunted one with 2 negative tap tests elsewhere. But instinct and everything else said, you know, she's going to respond. And thank God we did, because she responded really well. About those patients who are negative tap test,
Yes,
or
but
had a test somewhere else, and then you think, well, he or she really looks like, especially the more older ones. I wonder what you think.
how did they did that tap test? Did they do it correctly? Did they lower the pressure to 0? Did they use an 18 needle? Because if they only took out 20 cc's and they didn't lower the pressure, if you had 150 and they left the pressure in 80, you didn't do anything. It's still normal pressure. You need to lower it to 0. That's the first thing you have to see, if they did the tap test correctly. Because if they didn't do it, they didn't do anything.
So does that mean if you get a patient and you lower it to 0, and quite often in another unit, you don't know what they've done precisely, but if you lower it to 0 and they don't respond, their turnaround time is not massively improved, their walking is not massively better, do you say no to them?
Did you see how was a neuropsychological test? That's why it is very important.
Yeah.
Neuropsychology will tell you this patient really has, it's typical of MPH, but no, it's typical of Alzheimer's. No, it has both. That's a very important part. How is the gait? I mean, if the gait is magnetic gait, compass, that patient is MPH. And I'm sure that if you do the lumbar test, the tap test correctly, or the test you do correctly, that patient is going to definitely do good with a shunt.
That's very, very helpful. Thank you, Fernando. Really, really good. One other quick comment and maybe a question is, and I sympathize regarding the VA shunt. And I remember you said the same thing in another international meeting, that when you highlighted, I think it was in Kobe, that majority of the shunts put in Colombia with VA. Culturally, it's a huge thing. As you know, in Japan, they're LP shunts for no good reason, in terms of, well, no scientific reason. A lot of it is cultural. And I'll share an example. I think I've said this before. In aneurysm surgery, depending on who you trained trained under in UK, surgeons would tap the ventricle on table before doing the aneurysm, you know, getting exposure of the basal cisterns and the vessel in question. And a lot of other surgeons would just put a lumbar drain. And it was purely who you trained under. I personally would prefer a lumbar drain any day. And a VA shunt was also similar, depending on who you trained with and your exposure and how you were trained. The problem with the VA is that everyone dreads the shunt nephritis and the septicemia and the terrible, rarely seen shunt nephritis these days, because very few people do VA shunts. What's your experience with that in terms of serious complications of VA shunt? Is it very rare? Do you very rarely see it now?
Yes, I've seen in my life. I trained in 30 years ago. I saw 2 patients in my residence with shunt nephritis. And I've seen in my hospital in like almost 30 years, I've seen 1 case or 2 cases of shunt nephritis, really. It depends on how you do. That's very important, how to shunt the patient, how many people, you know, Mauricio, how he's doing, how he has these rules of how to shunt, how to do the surgery. And now a doctor in Canada, Dr. Hamilton. Yes, I'm sorry. Hamilton. Yes. I'm sorry. Hamilton, he has 0% of infection. It's very important how he's doing. It's 0% of infection. That means why the shunt nephritis? Because the shunt was contaminated during surgery or afterwards. Depends on the patient. Yeah. But I mean, shunt nephritis it can happen. But you can also have an infection in the peritoneal cavity, which is not as bad. But I mean, it can happen. It can be bad. But I think it's worse to have a patient that you believe that the shunt is working and it's not really working because it is in the VP. I will show you why I believe it's not working. I've seen it, and I show you what we do and why the patients do a lot better. So that's why we do VA shunt, in my opinion.
No, absolutely makes sense. And the lower end obstruction is incidence is much lower. Look, that's really, really educational. Fantastic. Thank you, Fernando. I personally learned a lot, and Georgia's done a fantastic job at bringing on all the questions. Georgia, is there any more questions you think that are from the very keen audience, or should we call it a day? I think we've had a good innings, haven't we? Fernando, a huge thank you to you. Really, it's fantastic what you've done and your team, and in keeping with your father's legacy. For me, one of the wonderful things is the service that's been done to neurosurgery in Latin America. You know, it's put neurosurgery in so many ways on the map in that continent, and to raise standards to such a high level. It's wonderful, absolutely brilliant. And now we're getting to a stage where we're learning so much from each other, from different parts of the world. And it's not like, you know, there's one or two places which are beacons. There are beacons all over in each continent. So really, really fantastic. A huge thank you to Fernando, and thank you to Giorgio as well.
Thank you.
Wonderful. God bless. Thank you, everyone. And thank you for joining us. God bless you all. Wonderful.
Thank you.